to ask all speakers to come to the stage for the panel discussion. And while they're doing so, I'd like to share a few thoughts to recap. I think, Constanza, you made a very, very important point on pointing out that we need to differentiate between prevention and identifying gastric cancer. It's completely different biomarkers we're talking about, and I'm grateful to Meira to bring Khay back to the stage. I think this is such an easy and completely overlooked biomarker which we already have at our hands. But all the biomarkers we have are only as good as the diagnosis we get from the pathologists. So I think that's extremely important. As long as we don't have accurate diagnosis, we don't really know how to use or how to validate those biomarkers. And that's where the studies from Singapore, I think, will be extremely helpful, because I think we all agree intestinal metaplasia is, let's call it an epiphenomenon, but it's not the precancerous lesion itself, it's the stem cells. And we need this in-depth single cell resolution to understand what happens in the stem cell, and the stem cell transcriptomics may give us new biomarkers really to use here. Yeah. But without anticipating too many, please, for the first question.
Thanks for that very interesting session. I have a question on the GastroClear. So there's a dozen microRNAs, right? What do you consider a positive? Do you have to have all 12 of them aberrantly expressed, or is it the majority?
Yeah, thank you for the question. So GastroClear is a panel. It's a panel of 12 microRNAs. The panel reads out as a score. So a positive score is a score above 50, and then there's a borderline gray area, and then there's a negative. So the score reads out into a positive, borderline, or negative.
So it's a composite. So my concern with microRNAs is that they're often aberrantly expressed in cancers of multiple tissue types. So in your 32%, I believe, of patients that had a negative, presumably negative endoscopy, but a positive GastroClear, do you know if the patients had tumors in other tissue types?
Yeah. That's an excellent question. So we've done the microRNA studies so far across 3 types of cancer. So stomach cancer, breast, and colon cancer. And we looked at whether the microRNAs in these 3 cancers were the same or different. So the answer to that is most of them are different. They're distinct. The microRNAs that are positive or differentially expressed in gastric versus colorectal versus breast cancer largely are different. There is a small number, I think it was 4 or 5 microRNAs that were similar, commonly expressed in 2 or more cancers, but most of them were distinct.
Did you happen to look at stool?
No, we haven't. The reason why we're attracted to study in microRNAs is that they're very stable. So that's one advantage. About 12 years ago, we were examining different types of biomarkers, including proteomics, DNA, biochemical markers. So we largely gave up proteins because they're not very stable in the blood specimens, especially if they are not rapidly processed in the lab. They're subject to artifactual changes. It was also much less easy to be consistent. So in contrast to that, the microRNAs being very short fragment, they're only about 20 to 22 nucleotides, very stable and therefore reliable and consistent.
Thank you.
Hi, I have a question for Dr. Piazuelo. Thank you very much for the incredible lecture and connecting pathology and endoscopy. My question is, because I heard from other pathologists that it's kind of subjective to grade the severity of GIM, and it's variable how pathologists across different type of practices report the GIM. So do you know if there's any report on the adherence of how to report the GIM standardized? And secondly, I heard, it's because it's subjective, so you can't really trust, but for your explanation, it's not that it's very subjective. There is an objective measure, but actually, because it takes time and some effort, so not no one, but humans by nature are lazy, so maybe that's what happens, and if it's really subjective or if there's any way to improve. And I think my take-home message is that we need to have multiple copies of you to put in all the clinical trials we want to do, because otherwise, if gold standard is pathology and we can't really confirm, so then probably it's important for us, even in these feasibility trials, is to see how your pathologist is, and if there's inconsistent, then you have to have a panel or something like this.
Yeah, thank you for the question. I think I have been very lucky that I found Dr. Correa as my mentor, and I worked with him for many, many years. So I understand that pathologists here in the United States that are not trained at all to subtype intestinal metaplasia, for them it's like speaking another language, and because their mentors and their professors don't encourage it, they don't learn it. Mm-hmm. So for them, they don't care, and because of the guidelines don't say do it, they don't do it. So I've had many conversations with Kay Washington at Vanderbilt, that she's an amazing, one of my mentors, GI pathologist. And so she agrees totally that, of course, we need to do it. And it's easy to do it, but you just want to do it. You just need to want to do it, and professors, and they need to be exposed to learning that from residency. So until the field moves forward and it's a necessity for the gastroenterologist, so the more you push your pathologist, the more the awareness is going to be incrementing, and they will learn over time. Because I think the main confusion is the incomplete metaplasia. For me, after all these years looking at biopsies, I know that the complete is very clear. I mean, the characteristics are very specific, and when you see it, and that's it. And you have to have panet cells also involved, and that's a very, very important component. I have seen papers that they ignore the panet cells. I mean, everyone does whatever they want, and I am not saying that my point of view is the correct, but what I've been learning all my life since Dr. Correa trained me. And when you see the incomplete is a bag of a lot of different spectrums. You can see anything, and that's where it comes the spectrum from intestinal metaplasia to dysplasia. You see it in the background of incomplete metaplasia. Because that picture that I show you about those glands that are irregular and the nuclei start to be disorganized, that's not complete anymore. So when you see that, and when you see dysplasia, it's in the background of incomplete metaplasia. And somebody was mentioning yesterday in a talk, I don't remember who, but they were saying, the pathologist that says dysplasia, and then we go back to the endoscopy, and we don't see it. Mm. And yeah, you don't see it because the dysplasia is, usually when we see it in biopsies, it's just one gland or two. So it's so focal that when you do serial sections, oh, let's see better this thing, or let's do additional stainings or whatever, you do 5, 6 more sections, and then you don't see it. So that's the issue with the incomplete metaplasia and the dysplasia. That is a continuum that, I don't know, of course, when you have one cell that is already metaplastic, I don't think the same cell is going to become cancer, but I think the stem cells within that area are the ones that are collecting changes and mutations, and then from there arises the dysplasia. So I understand that they don't want to do it, but I understand also the heterogeneity in pathologists doing it. But if there was a way that we could, teach that the complete is complete, and that's very clear, and the rest is incomplete, because I understand the incomplete is many different, it has many different phases.
And you feel the same for the severity? Because it's like
according to
percentages. So
severity is like the extent. It's like 1 to 3 severity, and that's very well explained in the Olga-Olgin system. See, if only talk about metaplasia, it would be the Olgin system. So it's depending on the percentage. Of course, it is subjective, because I can look at the biopsy, and I'm not going to count the glands, and some glands are bigger than others. So it's more or less accurate, but of course there will be some variation. So I think with the machine learning, maybe that would be more precise than our eyes.
Thank you.
I rush to defend the pathologist, because the GI pathologist is a gastroenterologist's best friend. I think the consistency is greatly helped by having a structured system. So if you use OGIM and so on, I think there are publications where the correlation for OGIM reading is up to about 0.9. So that's pretty good. It's if you don't use a system when the subjectivity causes a lot of variation.
Okay, thank you.
And I have an add-on to that question then. Do you have a sense of how prevalent it is being used in America and also around the world? And I ask this to understand how much work we need to do.
Okay, in America, I don't know, but I know it's very low. Only in places like here, or very people that are only focused on that. But I don't think in the United States pathology do that. What was the other question?
Around the world.
Around the world, also very few places. In Chile, I commend the pathologists from Chile, because they not only do OGIM, but Olga, which is more challenging. And I was impressed at all the amount of work that takes, because OGIM is a lot easier due to the metaplasia, and that's clear. But the Olga, you have to start thinking about the atrophy plus metaplasia plus pseudopyloric metaplasia, and you actually have to do scores biopsy by biopsy and then work on the score. So around the world, I think it's Chile probably, and they have these guidelines since 2004. So I think they were the first ones in adopt that system. I don't know if in Europe. I remember last year or 2 years ago we were in Italy, and one of the
I would say.
And the pathologist would say, "No, I will never do that." He was in the group of the gastritis, whatever consensus. He was like, "No, Michael."
I'd say it's pretty well accepted in Europe, and we have some people really pushing it a lot, like Michael Feet. But
He said he would never do it.
he does. But we're on the other side having whole meetings discussing the value and the practicability of it. So it's used, but it's still critically discussed.
So in America, where we're still trying to figure out which way to go, does that mean that, like Asia, you do it without biopsies and you just use the endoscopy to do it versus pathology?
I think that's the way to go. I don't know. I don't want to discourage
You're gonna put yourself out of a job.
Yeah, I don't want to take me out of job. But anyway, when the endoscopy is here, we'll get to that. I will probably be retired. But I think that is the best way to go, because if you know how to see it, you don't need like blind biopsies that maybe are not representing what you have.
Another question?
Thank you. That was really, really cool. I'm a postdoc in Manuel Amiva's lab, so we look at a lot of stem cell H. pylori interactions, and my background is more like host microbe interactions training. So I learned a lot in this conference. So it was really cool. And I want to ask about KAG-A, since it's not really an essential machinery for the bacteria, and it has been, I think, shown that they sometimes also use it in terms of iron limitation, so it's a bit of a nutrient acquisition machinery also for the bacteria. I was wondering if KAG-A injection goes up if you use antibiotics, and if so, let's say if antibiotic treatment fails, you ramp up KAG-A injection in the bacteria, but you don't kill them, and then maybe after that you have increased gastric cancer because you just make them angry in terms of, or you starve them or you stress them.
That's a great question. actually don't know the answer. I don't know if anyone here knows the answer to that. That's an interesting thing, and obviously it goes back to what Markus was presenting before, too.
Yeah. So KGA is the oncogene of the bacteria, right? Is starting with the variation across populations. We have East Asian populations with a very high prevalence. I will say 95% or so infected individuals. We have KGA positive strains. In Europe, I will say that is about maybe 50%, Markus. And in Latin America, is about maybe 70%. In the US, is a mix. The injection of the KGA is, according to some animal models from Vanderbilt, Dr. Cover, is more effective with salt, high intake of salt. So that's important because I think that explains the perfect storm, as Dr. Correa will call it, of high intake of salt, which is one of the recognized risk factors for stomach cancer, plus KGA. So the injection is more efficient, so there is more inflammation. It's an acquired gene. It's not part of the core gene, according to several studies, and also something that we confirm in the H. pylori genome project. But there are other genes that somehow compensate the potential effects and also elicit some inflammation. That is the case of HOPQ, and those have been seen in the GWAS of the bacteria, not the human, but just the GWAS of the bacteria. But KGA is one of the strongest ones, but potentially there are others that have relatively modest effects that may be combined using the same concept of the polygenerase score will lead to something else. But I think that in general, gastric cancer, considering that we have more than 5 billion people infected globally and just 1 million cases of gastric cancer per year, it's like that, just state that potentially cofactors are really the real drivers of gastric carcinogenesis.
Just to add on, I think early in the day we heard the question, it was a dilemma or question, why in South Asians the Helicobacter infection rate was very high and yet gastric cancer was low in the same population. And we have a lot of South Asians in Singapore and Malaysia, so when we did our population studies, the answer is that in the South Asian Helicobacter strains, CAG-A is low, whereas in the East Asians, CAG-A is very high. So in Chinese and East Asian populations, CAG-A is about 95 to 98%. In the South Asians, it was more like 30 to 50%. So it was much lower in the South Asian population. So we think CAG-A is like Constanza was saying, so it's a very important oncogene, especially with environmental factors.
I just want to add a quick comment to the same questions. That I wonder that in your study, you mentioned that Dr. Gerhard study that's a great study that did you measure the CAG-A in those failed treatment to see whether it's like a concentrated cohort of CAG-A positivity? That may explain why they have higher risk of cancer. And just a guess.
Unfortunately, not yet. We discussed this earlier that so many sub-analyzers are pending, and in this case, it's 200,000 serum samples we have stored, and we just need to find the means to really analyze all of them. Yeah. But it's a very good point, and it actually brings me to a question I wanted to bring in. It's actually two questions, and one is when we're talking about such serum biomarkers like KGA antibodies, we're only talking about this as a pool, and I think we need to think more about function. Thomas Boren, I think had this eye-opening study on BAP-A antibodies showing that some of those may actually prevent translocation and thereby disease, and nobody has ever looked if that the same would be true for KGA. So I could well imagine that there is protective antibodies and antibodies only indicating KAG-A presence, and that's why the picture is always a bit unsharp, what we're seeing when we're only measuring antibodies by ELISA. The other in that context is we've talked about all those potential risk factors and how they may relate to biomarkers, and we are exclusively looking at the epithelial cell. At the same time, we know that the immune response is, and especially the cellular immune response, is one of the strongest risk factors for cancer development. So why are we not leveraging this kind of immunity in all our thinking about biomarkers? We're trying to find the needle in the haystack of a microRNA or a point mutation or something that may indicate a higher cancer risk, but we know that CD8 cells, Th17 cells greatly contribute to cancer development. So how could we bring this into our panels?
Constanza.
I thought that it was more like a commentary. Yeah. No, I completely agree. Yes. But in terms of inflammation, for example, I think that somehow the digestive tract is by nature inflamed, no? Because it's part of the system to have all these, right? So to have a signal coming from the gastric mucosa, trying to get that in circulation is really difficult, right? So in that sense, I think that something with stool or even saliva, right? But absolutely, it's like we need to address all fronts and see and start adding just to push sensitivity.
Yeah, but I think it's possible. Just to give you one example, because we've been discussing this interaction with colonoscopy and yeah. So we do find Helicobacter pylori CAG-A specific CD8 T cells in the colon. And they seem to contribute to colitis. So I think the responses are there. We just need to find the right way to measure them.
Yeah. All right, and with that, we're going to close this session. Thank you for such an engaging talk.